I'd like to introduce our speaker today, Dr. Siddharth Jain. Dr. Jain is a pediatric neurologist and epileptologist at the University of Louisville, where he serves as director of the Infantile Spasms Program and co-director of the Outpatient Epilepsy Program. His clinical and research interests focus on pediatric epilepsy, neonatal EEG, and optimizing diagnostic and treatment pathways for early life epilepsies. He is actively involved in the national collaborative efforts through the Pediatric Epilepsy Research Consortium and the American Epilepsy Society. So thank you for joining us today, Dr. Jain, and I'll turn it over to you.
Good day, everyone. It's a pleasure to be here with you today. I'm a pediatric neurologist and epileptologist here at Norton Neuroscience Center. Today, with this presentation, we are embarking on a journey through the intriguing and the complex world of new-onset seizures in pediatrics. We will be diving into a case-based approach and then understanding how EEG and network models can help understand these complex symptoms and overall the diagnosis and management of epilepsy. As we explore these cases, think of them as stories, each with its unique narrative. And today, together, we'll uncover the intricacies of pediatric seizures. So let's set the stage and prepare to delve into some of these fascinating cases. The objectives of today's presentation would be first to identify what are seizure and non-seizure related events. The distinction is crucial for accurate diagnosis and treatment. Next, we will discuss the importance of localizing seizures using semiology, which involves observing the clinical features of seizures to determine their origin in the brain. This can guide us into tailoring treatment strategies more effectively. Next, we will discuss who needs an EEG, MRI, or hospital admission, go over the criteria to help make these decisions and ensuring that each child receives appropriate care. Understanding EEG patterns in another clinical aspects, we'll just touch base on the utility of EEG in the diagnostic evaluation of seizures and the diagnosis of epilepsy. Identify risk of recurrence and make a diagnosis of epilepsy. Recognizing these risks early on would be vital for ongoing management and intervention. So starting with, what do we think, what's a seizure? A seizure is essentially a result of abnormal electrical activity in the brain, which manifests as a clinical event. A seizure is characterized by three features. First, it's transient, meaning it comes and goes without lasting effect. It's like a brief electrical storm in the brain. Seizures are stereotyped. That means they follow a predictable pattern each time they occur. And they are network driven, which means that their patterns and the sequence of symptoms that happens in seizures follows some of the well-defined brain networks. And it can understand why seizures can present in various ways, depending upon which part of the brain and what network they involve. Understanding these characteristics is crucial because they help us identify and differentiate seizures from non-seizure events, leading to more accurate diagnosis and treatment. Next, we'll explore the differences between seizures, which is a symptom, and epilepsy, which is the disease underlying many children with seizures. By itself, seizure is the single event by itself. It's important to understand the difference between the seizures and epilepsy, because seizures being an isolated event is just characterized by the electrical activity in the brain leading to that one particular clinical episode. In contrast, epilepsy is the underlying disease or condition where an individual experiences recurrent seizures and or is at high risk of having them in the future. Highlighting these distinctions is crucial for diagnosis and treatment planning. Next, we could also try and understand the classification of epilepsy. Understanding the different types of epilepsies can help us tailor effective management for each of these patients. Epilepsy is broadly classified into focal and generalized types, with each having distinct characteristics and implications for treatment. Focal epilepsy originates in a specific area of the brain, leading to symptoms that can vary depending upon the affected area. On the other hand, generalized epilepsy involves both hemispheres of the brain from the onset, often resulting in more widespread manifestations. But before we go into types of epilepsy, let's review what leads to the definition of epilepsy. Conceptually, epilepsy is defined as a disorder of the brain characterized by an enduring predisposition to generate epileptic seizures. But what does that mean in clinical practice? We're talking about at least 2 unprovoked seizures, more than 24 hours apart. Alternatively, more recently, this definition has been expanded to include some patients with 1 unprovoked seizure, along with if they have clinical features or diagnostic tests that indicate that they have a probability of further seizures greater than 60%, similar recurrent risk to patients with other 2 unprovoked seizures. In addition, they can also be diagnosed as epilepsy if they've had a single seizure, but they have clinical features, characteristics, or more likely EEG findings that is very characteristic and specific for diagnosis of an underlying epilepsy syndrome, such as childhood absence epilepsy, juvenile myoclonic epilepsy, and West syndrome, or infantile spasms. Let's talk about the various semiology that seizures can present with. Careful observation of what happens during a seizure can provide critical localizing information before we have done any testing at all. Video EEG monitoring is a gold standard for capturing and analyzing the seizure semiology, but in the clinic, well-detailed witness descriptions are absolutely invaluable. And this is usually our first step in evaluating any patients with seizures. When you're taking the history, we ask open-ended questions to the observers, tell me what you saw, and then we get specific about what was the first thing that happened, which body part moved first, was the patient aware, could they respond, how long did it last, and what happened, and how the patient was reacting after the episode was over. Talking about the semiologies, they are generally classified, the seizures by themselves are classified into focal, generalized, or at times unknown onset, where the seizure may not have been witnessed in its entirety, and sometimes the caregivers may have arrived after the seizure was well set in. To understand the classification framework, there are 3 levels that we try to understand the patient's symptoms. One is the seizure type. The second is the epilepsy type. And then the third, what is the underlying epilepsy syndrome? The seizure type is where we start with. Was it focal or generalized onset? This is a very important classification that we try to understand very early in the description of the event. As we discussed, focal seizures arise from networks limited to 1 hemisphere, whereas generalized seizures engage bilateral networks. There's also a third category, unknown onset, for when we don't have enough information, as we discussed. Once we have determined onset, then we go further in our classification based on awareness. Was it focal aware or focal impaired awareness? That helps us understand how broadly the networks were involved. And what are the motor features for these events? Were they tonic, clonic, myoclonic, atonic, or automatisms? Or were there non-motor symptoms such as sensory, emotional, cognitive, or autonomic? The next step, once we have determined the seizure types, that we zoom out and try to understand what is the epilepsy type that they have, whether they have an underlying focal epilepsy, generalized epilepsy, or a combined focal or generalized epilepsy, which we'll discuss in a little bit. There are epileptic encephalopathy syndrome, especially in pediatrics, that can have multiple seizure types within the same disease or syndrome. The classification, of course, is based on predominant seizure types, the EEG findings, and imaging. The next level is understanding what the epilepsy syndrome diagnosis is. And this is the most specific level, and this is what we really value, because the epilepsy syndrome is a cluster of features that occur together. depending upon the seizure types, age of onset, EEG findings, and developmental level of the patient. These combination can help us understand what syndrome the patient might have, which can then help us understand the prognostication for that specific epilepsy. It also helps us understand medication selection for that particular epilepsy syndrome. For example, childhood absence epilepsy, onset between 4 and 8 years. Brief absence seizures provoked by hyperventilation has generalized 3 Hz spike in wave on EEG, normal development, and generally an excellent prognosis with treatment and remedies by adolescents. And there are very specific medications that can help with this type of epilepsy with excellent response in general. Juvenile myoclonic epilepsy, on the other hand, has onset in adolescents with myoclonic jerks in the morning, generalized tonic-clonic seizures, sometimes absent seizures. But the EEG pattern varies a little bit, having generalized body spike waves on EEG, and usually requires lifelong treatment. So it tells us that the prognosis guides medication choice, informs genetic counseling, and helps with realistic expectations with families. A child with childhood absence epilepsy has a completely different trajectory from a child, let's say, with Dravet syndrome, even though both may have generalized seizures. Now, not every patient fits into a neatly recognized syndrome. Many will have focal epilepsy of unknown etiology. Some of them will have structural epilepsy, and that's okay, and that we can still treat them based on general principles. But if we do make a syndromic diagnosis, that really helps us really tailor treatment and provide very specific prognostic information and kind of other treatment guidelines, such as how long we expect the treatment to last, and what other seizure types and what kind of other clinical comorbidities do we generally expect with that form of epilepsy. As we discussed, focal seizures arise from networks limited to one hemisphere. They remain focal throughout, or they may evolve to what we call bilateral tonic-clonic seizures. Previously, we called them secondary generalization. We distinguish between focal aware seizures, where consciousness is preserved, and focal impaired aware seizures, where it's not. The semiology, what the seizures look like at onset, reflects the cortical region of onset. And we'll discuss that a little bit more detail in the upcoming slides. Seizure starting in the motor cortex will cause contralateral clonic jerking, whereas a seizure in the temporal lobe might cause an aura of déjà vu or fear, followed by behavioral arrest and automatisms. Understanding this anatomy may help predict the semiology and vice versa. Generalized seizures, on the other hand, engage bilateral networks from onset. Consciousness is typically impaired from the start, except in the very brief myoclonic jerks where the patients might not even notice. On EEG, we see generalized spike wave or polyspike wave discharges. The common types include absence seizures and staring spells, and myoclonic, which are brief staring spells, and myoclonic seizures with the brief jerks, and also tonic-clonic seizures, tonic seizures with stiffening, and atonic seizures with sudden loss of tone. Each of them has distinct features, and recognizing them helps us choose the right medication. Now we can go by the most common symptoms that you might see in a patient with focal epilepsy, depending upon the area of the brain that the seizures typically originate from. That can help us understand some of the less common and less obvious symptoms that may represent seizures in the general population. So, for example, let's discuss about seizures that may arise from the frontal lobe. The frontal lobe is the largest lobe of the brain, and seizures are second most common focal epilepsy after the temporal lobe. But they are frequently misdiagnosed. Let's see why. The typical features of this seizure may be at times. These are dramatic. Often violent appearing movements, thrashing, kicking, bicycling of legs, pelvic thrusting. These can arise from what we call the orbitofrontal lobe, which is and the mesial frontal areas, and they can sometimes look so bizarre that they might be appearing as behavioral event. Sometimes they present with what's called an asymmetric tonic posturing, stiffening that's more prominent on one side and tells you the seizure is activating motor cortex or the supplementary motor cortex contralaterally. This is different from the symmetric tonic stiffening that you may see in generalized tonic-clonic seizures. Head and eye deviation. Again, forced turning away from the seizure focus with eyes pointing in that direction reflects activation of the frontal eye fields in the posterior middle frontal gyrus. If the head turns right, think left frontal onset. These tend to be, frontal lobe seizures tend to be more commonly not nocturnal in seizures. These are brief nocturnal seizures that can emerge in non-REM sleep, particularly stage 2. They are short, often 10 to 60 seconds, and they can at times cluster. They may have about 5 seizures in one night and then none in a week. The nocturnal predominance is sometimes why they can be confused with parasomnias. Other features include speech arrest, sudden inability to speak during preserved awareness, such as involvement of the dominant frontal lobe, especially the Broca's area, supplementary speech area. Head version, as we discussed about fencing posturing, as we discussed about common features of this, seizures that are arising from the frontal lobe. Common misdiagnosis, as we discussed, behavioral event and parasomnias, and the bizarre motor activity, the nocturnal timing, the brief duration with rapid return to baseline. Usually, you'll have behavioral events that are much more prolonged and not very stereotyped and not that distinct with a rapid return to baseline, that you might see. Parasomnias like confusional arousals and night terrors can look similar, but the distinguishing features are the stereotypy. Frontal lobe seizures look identical every time for that particular patient, whereas confusional arousal, night terrors, it might be very kind of polysymptomatic, various symptoms, different activity going on, throughout the events, and the events may not look, exactly the same every time. Frequency, frontal lobe seizures may happen multiple times a week, and then of course the EEG that can help us diagnose with abnormal discharges over the frontal lobe. Temporal lobe is the most common lobe of onset, especially sometimes, especially as we go to adults and an adult age group, and for focal onset seizures. The aura is the biggest clue in the temporal lobe seizures. Common auras include an epigastric rising sensation, that is a feeling of something rising from the stomach to the chest. And usually it's almost consistent with the mesotemporal onset. Deja vu and jamais vu are also classic. Fear or dread without an obvious trigger suggests an amygdala involvement. These auras by themselves are focal or aware seizures themselves, and they are seizure before it begins to spread. Typically, what follows this is behavioral arrest. The patient stops what they're doing, stares, becomes unresponsive. And that's where it transitions from a focal aware to a focal impaired aware seizures. Next, you might see some automatisms appearing like lip smacking, chewing, swallowing, hand fumbling. These are again hallmarks for temporal lobe onset. The seizure may then progress to bilateral tonic-clonic activity or second lesionalization. And then you'll have the postictal phase. If you just have the aura by themselves, or whether that be with or without awareness, the postictal phase tends to be a key to diagnose them as seizures as opposed to other non-epileptic events that they might represent. Temporal lobe seizures have a prolonged postictal confusion periods, often several minutes, sometimes longer. This distinguishes them both from the frontal lobe seizures, which generally may not have that significant postictal period, from absence seizures, which have no postictal period, and from non-epileptic events, which also do not have a significant postictal period. Other fascinating features from temporal lobe, sometimes what's called a postictal nose wiping, where the seizure ends and the patient reaches up and wipes their nose. And usually the hand that they use to wipe their nose is the same side as seizure focus, because usually it's because that the contralateral hand or the hand involved with the seizure is weak or relatively less mobile, and they prefer the hand that's relatively normal. And it's called the Littmetzer sign. So, again, that's an interesting finding that you may see sometimes in patients with this condition. Of course, the common misdiagnosis or alternative diagnosis for similar symptoms include anxiety or panic attacks and daydreaming. And as I said, it's usually just the duration of symptoms, the post-ictal phase that can help us differentiate whether this is a focal onset seizure from the temporal lobe versus if these are alternative non-epileptic events. The non-epileptic events will tend to be longer in duration, will be having varying symptoms, and may not have a very clear offset into a clear post-ictal phase after the events. Parietal lobe seizures, they are less common than the first two lobes that we discussed. However, they can present with varying symptoms that can mimic other neurological findings, such as migraine, anxiety, convulsion disorder, and even peripheral neuropathy, because they might have some sensory symptoms with it. Typical features are positive sensory symptoms, tingling, numbness, pins and needle sensation that marches across the body following a somatotropic organization of the sensory cortex. That's called the Jacksonian sensory march. And it can be very localizing. It tells you that the seizure is spreading along the postcentral gyrus. Distorted body perception is sometimes under-recognized. Patients feel like their hand is enormous or the arm does not belong to them and the body is twisted in space. Spatial disorientation or vertigo can occur, especially with inferior parietal involvement. They usually spread to adjacent areas, temporal, frontal, and occipital. And sometimes if these early symptoms are either not reported or not remembered because they seem to be more subjective and sensory, and if there is some post-ictal amnesia, the semiology may actually reflect the area of spread than the area of onset. And that's why sometimes it can be difficult to diagnose and may appear that the seizures are arising from, let's say, the frontal or the temporal lobe instead. The other common diagnosis that produces similar symptoms is migraine with aura. Both can cause sensory symptoms of onset. However, the difference is the epileptic sensory march is fast. It's a positive phenomenon as opposed and evolving over seconds. Migraine aura evolves much more slowly, over 5 to 20 minutes. Epileptic events are brief and usually lasting under 2 minutes, whereas migraine aura and then the headache lasts much longer. And the migraine aura can have, again, more varying symptoms, whereas epileptic events tend to be very stereotyped. Occipital lobe seizures are usually about visual phenomena. There is the primary visual cortex here, so the seizures in this region may give rise to visual hallucination. Occipital seizure hallucinations are typically elementary, meaning that they're simple shapes, colored lights, flashing spots, zigzag patterns. They're not complex formed images like faces or scenes. Usually when you see images, people, animal, or detailed scenes, they usually will involve some association areas or even the temporal lobe, not necessarily the primary visual cortex. The visual phenomena, again, are brief and stereotyped. It's the same phenomena that would happen every time with seizures arising from this area. There can be eye deviation, forced blinking, fluttering because of the proximity and rapid connection sometimes to the frontal eye field. It's an occipital frontal pathway where seizures can spread very fast to the frontal lobe from the occipital cortex. Once they start with visual symptoms, most frequently they'll spread anteriorly to the temporal lobe, causing temporal lobe symptoms like automatisms and impaired awareness, or sometimes to the parietal lobe. So if the visual for aura is either not reported or not recognized, the seizure might look temporal or even parietal in nature. Again, the differential lies with migraine, and as we discussed with the parietal lobe seizures, the differentiating features between migraine and seizures, with the migraine aura usually building up much more slowly and evolving much more gradually, and epileptic visual symptoms localized to just one hemifield, having much faster built up and very stereotypic symptoms. And the fifth lobe, the insula. This is a hidden lobe at the junction between the frontal and the temporal lobe, buried deep within the sylvian fissure, and it's not visible from the brain surface. Insular seizures can be very difficult to diagnose for this, even sometimes using EEG, as the EEG features may or may not be readily apparent on the surface. The features of seizures from this row represent its role in integration of various sensations. So there are visceral sensations and autonomic function that might be seen with seizures arising from here. Throat tightness or choking sensation, chest discomfort or pressure, laryngeal sensation, diffuse autonomic symptoms, flushing, sweating, tachycardia, and pain. Insula is one of the cortical regions where seizures can actually cause pain and often described as burning or electrical sensation. These symptoms can mimic panic attacks, cardiac disease, or reflux, and that's why at least the start of these, or if there are mainly just aura-only symptoms, they can be very difficult to be diagnosed and may commonly diagnosed as alternative etiologies. As I said, the diagnosis is challenging even with EEG, with the insula being deep, and sometimes either the insular discharges are not picked up or they may appear much more diffuse and not just localized to that region. And they may certainly may appear as generalized or more diffuse forms of epilepsy until we get to further course of seizures, or we do further testing. If the MRI shows a lesion in the insula, or we need to do what we call stereo EEG, where we place depth electrodes directly in the insula to confirm the diagnosis. Some special areas, supplementary motor area, which is part of the frontal lobe, can produce very characteristic, although sometimes misdiagnosed seizures. The classic sign is a fencing posturing with one arm extended, the other flexed, creating what we call a figure of four. The extended arm is contralateral, whereas to the seizure focus. And that's very highly specific and a reliable lateralizing sign in epilepsy. Awareness can sometimes be preserved, but they usually tend to be nocturnal. They are brief, lasting about 10 to 30 seconds and occurring in clusters. Multiple seizures can happen at night and then nothing for days. It's on the mesial surface, again, not directly underlying the scalp electrodes. And that's why sometimes, we might see not such direct signs on the EEG, but indirect signs such as slowing or evolving patterns. But frequently we'll see movement artifacts because of all the movements, and the motor changes with these seizures. Further clues, if we do not have specific lobar semiologies or classical semiologies, again, language disturbance points to involvement of the dominant hemisphere, which is left in about 95% of right-handed people and even 70% of left-handed people. They would be, again, either difficulty to speak, speech arrest without confusion, and then post-ictal aphasia that can be seen if the dominant lobe is involved. In the non-dominant hemisphere, typically the right, and seizures do not produce a language dysfunction, but there might be other symptoms such as emotional autonomic symptoms, spatial distortion, or neglect that may be seen if these are involved. Now let's talk about some special ictal phenomena. These are unusual, sometimes bizarre symptoms that may not, be always recognized as epileptic or seizures, but may rarely present some very specific forms of seizures. One of those are what's called gelastic seizures, and comes from the Greek word gelos, meaning laughter. And they are characterized by inappropriate mirthless laughter or giggling. But this is different from the emotional laughter in that it's not associated with happiness or amusement. It's empty, it's automatic, it's forced. The patient feels disconnected from it, and you know there is no emotional component, and it's abrupt, and it's very stereotyped every time that's happening as well. In young children, gelastic seizures are associated with a very specific diagnosis called the hypothalamic hamartoma, and hence, getting an MRI to evaluate for this tends to be, one of the first steps in diagnosis for these symptoms. The other is ictal vomiting, is a vomiting that occurs as a part of the seizure itself, not post-ictal nausea. Post-ictal nausea is common with various seizure types and can happen after secondary or primary generalized seizures. But if the vomiting itself is part of the seizure symptom, then they can suggest right temporal or insular cortex involvement. The insula, again, as we said, that is a hub for autonomic processing, and that's why ictal vomiting can be a common feature of that. It can also be seen as a part of some of the occipital onset seizures, sometimes even in benign occipital lobe epilepsy of childhood, and usually happens because of spread of discharges to the temporal lobe, which then activates the autonomic symptoms. Ictal spitting, where there is repetitive stereotype spitting during a seizure, again points to insular cortex involvement. Again, this is even rarer than ictal vomiting. Ictal urinary urge, again, a sudden, overwhelming, irresistible need to urinate during a seizure associated with right temporal lobe seizure. And finally, piloerection, which is goosebumps occurring during a seizure, reflecting autonomic activation, and can occur with temporal or frontal lobe seizures. It suggests involvement of cortical region connected to the sympathetic nervous system, and they can be unilateral or bilateral. And when unilateral, they will have lateralizing value to the contralateral cortex. So some of these rare phenomena are more subjective or autonomic or visual processing phenomena, more likely from the insula, temporal lobe, and as you talked about, or the hypothalamus in case of the gelastic seizures. So just summarizing some of these localizations here on this slide, as we discussed, epigastric aura for mesotemporal onset, head version for contralateral frontal onset, colored visual aura for occipital onset, tingling and sensory symptoms for parietal onset, hypermotor nocturnal seizure symptoms for frontal onset, speech arrest, suggesting dominant frontal lobe, post-ictal confusion with the temporal lobe, and the Jacksonian march with the motor cortex. Next, we can go on to and discuss some case scenarios and apply this knowledge of understanding, what is a seizure, what epilepsies can they be a part of, and in case of focal seizures, what are specific symptoms and signs that can point us to where seizures might be coming from. So in this case, we have an 8-year-old boy who's been having brief nocturnal episodes. His parents described sudden bilateral leg kicking and arm posturing, and these episodes come out of nowhere. They're very stereotyped. They look same every time, and there is no post-ictal confusion. He's back to baseline immediately, and each episode lasts less than 60 seconds. So they are happening multiple times a week, often in clusters. We're thinking, are they frontal lobe seizures versus parasomnias? As we mentioned, the stereotypy, the frequency, and the lack of post-ictal state, and just the duration of how short and stereotypic they're all clues. We got an EEG, and it shows left frontal sharp waves at the EEG locations there. The semiology fits with the frontal lobe onset, as we discussed for the features of how the duration is, the nocturnal occurrence, and then lack of post-ictal state, which is a feature of the frontal lobe seizures. And then the EEG finally kind of confirming the diagnosis and the seizure onset area. What else could similar symptoms be? Parasomnias, confusional arousal, sleep terrors, non-REM parasomnias in general, and even psychogenic events. Psychogenic effects are, of course, less likely given that they are arising from sleep. The key distinguishing features, again, stereotypy strongly favors epilepsy. For the parasomnias, they usually are much longer, lasting for minutes. Semiology is variable. Movements are diffuse and not very specific, and they tend to be sporadic and don't tend to cluster. So, that's why we think, this is a case of frontal lobe epilepsy, and in this case, arising from the left frontal lobe. The next case, the next scenario is about a 7-year-old girl whose teacher is concerned because she keeps zoning out in class. These episodes are very brief, lasting 5 to 10 seconds, with abrupt onset and offset. There is no aura, no post-ictal confusion. She just stops what she's doing, stares, and then resumes as if nothing happened. The teacher reports this happening multiple times per class. Mom initially thought she was just daydreaming, but the frequency is concerning. So, what's on our differential here? Is it just normal daydreaming, complex partial seizures, or absence seizures? So absence seizures are brief, frequent, and can be provoked by hyperventilation. And that's key because that's a test that can be done right in the office. We frequently use a pinwheel and we'll ask the child to hyperventilate for 2 to 3 minutes. And if we can reproduce the symptoms, and we'll see a clear behavioral arrest and sometimes some automatisms, that frequently clinches the diagnosis. On the other hand, complex partial seizures, they will tend to be longer, less frequent, and often have a post-ictal period. The EEG can readily make that diagnosis. So let's get an EEG. And here, as we see, it shows the classic 3-Hz spike wave pattern, and we were able to provoke them with hyperventilation. This is classic staring spells, abrupt onset and offset, multiple daily episodes. Prognosis generally is excellent with appropriate treatment. Ethosuximide or valproate can be first line, and most kids will outgrow this by adolescence. We do need to monitor sometimes generalized tonic-clonic seizure may occur in a smaller proportion of these children, sorry. Here's another case. Again, staring or behavioral arrest, 12-year-old girl with episodes of behavioral arrest followed by lip smacking and hand fumbling. These last about 1 to 2 minutes. There's post-ictal confusion for several minutes. She describes what we call an aura of rising epigastric sensation, a feeling arising up from the stomach just before the episode starts. So this differential includes complex partial seizures. Can they be absence? Can they be temporal or frontal in onset? The duration and the post-ictal state argue against absence seizures. Also the stereotypy and the duration of the events is also not typical for psychogenic events, which tend to be much, much longer in duration. They point towards a temporal lobe epilepsy, as opposed to a panic attack or a migraine where there are no automatisms. Awareness is generally preserved and there's no clear post-ictal state, and the presentation is usually much more variable, whereas these are more stereotyped events. The EEG in this case shows left temporal short waves, we should get an MRI to look for a structural abnormality in this case, treatment can involve treating with medications, and if they're refractory, they could be a surgical candidate as well. Next is a 16-year-old girl who comes in with brief jerking movements of both arms happening in the morning. There's no loss of consciousness. He's dropped his phone a few times. The jerks are worse after sleep deprivation, like staying up, studying late, or gaming. And there is a family history of epilepsy. Is it just tremor? Is it psychogenic jerks? Is it just myoclonus or a myoclonic epilepsy? With the age of onset, and the features of morning myoclonic jerk, and at times we get either history of photosensitivity or photosensitivity on the EEG, sometimes progressing to generalized tonic-clonic seizure. This would be very characteristic for juvenile myoclonic epilepsy, also called JME. And family history is very common in this condition, and as is a good proportion of patients can have a history of febrile seizures when they were children. So EEG, in this case, has characteristic which show generalized polyspike and wave discharges. The triad for this diagnosis is myoclonic jerk, especially in the morning, generalized tonic-clonic seizures. Sometimes a small proportion of patients might have absence seizures as well. Triggers are sleep deprivation, alcohol, and photic stimulation. Valproate is very effective, but need to be concentrate in females of childbearing potential regarding teratogenic effects. And levetiracetam and lamotrigine are alternatives and tend to be more frequently utilized than valproate. The treatment for this condition tends to be lifelong, even though the seizures themselves in many patients may be infrequent, happening sometimes once a year or even less, but they usually do recur if medications are stopped in most of these patients. Now let's talk about some other symptoms that may appear like seizures, but may not always be so. A 13-year-old who collapses at school assembly after standing for 20 minutes. He felt lightheaded and warm beforehand. Witness noticed few jerking movements, but he had a rapid recovery and no post-ictal confusion. He was back to normal within a few minutes. Can this be epilepsy? There are distinguishing features of syncopal events versus generalized seizures, or even secondly generalized seizures, that can help us distinguish with what we're dealing with is an underlying seizure or an epileptic seizure with a higher risk of recurrence or progressing to more involved generalized tonic-clonic seizures. In this case, there was a trigger present. The patient was standing for a long period of time. Brief jerking can be common in convulsive syncope. About 30% of patients or more can sometimes at least have some transient motor symptoms that can happen in these cases. And usually there is a rapid recovery without a clear post-ictal phase or post-ictal confusion. The EEG tends to be normal. If we do get an event on the EEG, which we do sometimes not, it's not common to get that in older patients or children, but sometimes in, let's say, younger children with breath-holding spells, which is a form of convulsive syncope, we will see slowing during that phase. The EEG becomes very slow because of hyperperfusion to the brain. There are these classic features that help can distinguish between syncope and a seizure: lightheadedness, visual dimming, nausea, and sweating at the prodrome before the onset of the seizure. Again, there being a trigger, usually they're standing or changing position. The duration is short, movements are brief, arrhythmic, and there's a rapid post-ictal recovery. Tongue biting is rare, and incontinence is uncommon, not impossible, but uncommon, and EEG tends to be normal. These are features that are characteristically help us distinguish what's a syncope from a seizure. Another scenario, this is a 15-year-old who presents with episodes of whole body shaking lasting 5 to 15 minutes. Eyes are closed during the events. There's no incontinence, no tongue biting, no post-ictal confusion. Episodes happening during time of stress. EEG and MRI were normal. With a long duration, variable movements, preserved awareness, eyes being closed, emotional triggers. Some other features including patterns of breathing, rapid breathing, as opposed to slow or strenuous breathing that happens with a GTC. And if we do have an event on the EEG, having a normal background, having what we call normal features such as the posterior dominant rhythm during the event without any ictal correlate, these all would point towards what we call PNES, or psychogenic non-epileptic seizures. And this diagnosis is essential to make, as the treatment usually does not respond to anti-epileptic agents. And sometimes if the events continue, they may lead to escalation of the medication, addition of additional medication, but that does not really help the underlying cause or these symptoms. The treatment is usually psychological intervention, cognitive behavioral therapy, and they're not epileptic. And sometimes we do need to have these patients admitted either in the hospital or the epilepsy monitoring unit to confidently kind of make that diagnosis. But once it's clear, then the treatment is directed towards more of a psychological intervention. So, understanding, how seizures can present, what symptoms then they have, and what are the scenarios in which, and the cases, how typical forms of epilepsy present in childhood. I'd like to discuss just understanding some of the network models or a little bit more understanding of epilepsy rather than always understanding or thinking there's seizures arising from a single focus, but not as involving a more diffuse network. Again, these networks that exist in the brain having a balance of excitation and inhibition, whereas sometimes there can be a network disturbance without there being a very clear lesion. And that can happen in some of the genetic conditions, some of the conditions that affect various ion channels, sodium channelopathies, and others, where we might still have a very difficult to treat epilepsy, but they may not be a very clear lesion in the brain. And that explains why in many patients with epilepsy, we have normal MRIs, or we don't see a very clear cause, as it tends to be more of a network disturbance rather than just a clear lesion that's driving the seizures. Apart from generalized and focal seizures, in pediatrics, we commonly see a more complex form of epilepsy and a relatively newer terminology for this called developmental and epileptic encephalopathy, or DEE. In addition to having various and frequent seizure types, which usually start off in most cases as focal seizures, but may develop as generalized seizures as well, having frequent seizures rapidly involving the thalamocortical networks. There is frequent epileptic activity in the EEG, which by itself can at times be thought to be contributing to some degree of cognitive or behavioral impairment beyond what the underlying etiology is leading to. Example including Dravet syndrome or Lennox-Gastaut syndrome. In that case, patient either having, in LGS, either having an underlying stroke or brain injury that's driving seizures, also driving most of the developmental delays. But there is frequent epileptic activity that might, on top of their existing delays, might add more to cognitive slowing and sometimes even regression of their development, and requires more aggressive treatment, not just of seizures, but even sometimes beyond seizures, trying to see if we can improve their overall EEG burden of abnormal activity, where that may at times, at least to some extent, improve some of the developmental outcome. So these are definitely more complex scenarios, and these are patients that frequently do not fall into that clear bucket of focal or generalized seizures. And these are one of our most challenging patients that we see. So why does it matter? Again, as we said, why does it matter? Think about networks, onset, and also specific syndromes for these patients, whether they are focal, generalized, or whether they have underlying developmental epileptic encephalopathies. Is that because understanding how seizures evolve, you might see a patient with a convulsion, and if you just see that part, and you might be late in the seizure development and may look generalized, but may actually have focal onset. And some of the investigations, might have those clues, and sometimes even early investigation features like EEG may appear generalized with a bilateral synchronized discharge, but may actually be, more of a frontal lobe seizure arising from one of the frontal lobe. And if we are able to distinguish and basically dissect some of these symptoms, we may be able to come to conclusions of whether there is a more localized network or localized onset for some of these seizures, where we might have treatment options beyond medication, namely epilepsy surgery. So, understanding these symptoms, understanding the onset and develop kind of the evolution of these symptoms, kind of correlating them with EEG, MRI findings overall, then can help us give a better idea as to what we see, why the patient is having these symptoms, and what type of treatments can be offered, especially if the seizures are difficult to control. But when a patient, kind of putting this together, when the patient does present with their first unprovoked seizures, our workup involves obtaining a detailed history, and these are all the questions and clues that you might be looking into depending upon how the patient presented or what the event actually looked like. Obtaining a routine EEG yeah, is an important step in most patients where there is at least a reasonable clinical concern for underlying seizures or epilepsy. Again, neurological examination, and then MRI in certain cases where we are highly suspicious of an underlying focal epilepsy or a lesion, or alternative neurological conditions that seizures might be a part of. Let's talk about a little bit about the role of EEG in onset seizure evaluation. It helps us, why do we need an EEG and how it helps us not just in, let's say, confirming or ruling out a diagnosis of a seizure or epilepsy, but even beyond that, helping us understand better the underlying condition of the disease that's driving the patient's seizures. Firstly, it can help us classify, it supports the diagnosis, and that can help classify the seizures as focal versus generalized. It can assess to some extent the recurrence risk and severity of syndromes, depending upon how significantly and how frequently we see the abnormalities on the EEG. Interpretation of pediatric EEGs can definitely at times be challenging because we need to distinguish from normal variants from pathological discharges. That requires a certain degree of nuance and understanding, and sometimes, the discharges may be borderline and may require us to do longer studies. And importantly, beyond seizures, they can also help us detect just abnormal activity in epilepsy, namely during sleep. As we'll discuss in the next slides, there are many pediatric epilepsies and conditions that have activation of abnormalities during sleep that either can, define some degree or understand some degree of the recurrence risk, but also help us understand if there is kind of epileptic activity beyond seizures that may be impacting the child's development or cognition. So an EEG can be a key role in helping us diagnose and then prognosticate and understand kind of additional conditions that kind of go along with a patient who's just presenting with seizures. How's overall EEG performance? And that frequently, kind of gets brought up as to whether, how confidently can you diagnose or how confidently can you rule out epilepsy based on a single, especially just a single routine EEG. And there are some caveats to these numbers, specifically understanding whether whether it, of course, relates to quality of getting the EEG and how long the EEG was, but also importantly, whether we obtained sleep during the EEG or not. And that can sometimes definitely change some of these diagnostic numbers as well. And these numbers are a little bit different from what we see in adults, namely because, again, with a lot of the pediatric epilepsy syndromes, they tend to be more, we tend to see more active EEGs compared to some of the localized and focal epilepsies in adult. And also that, something that affects the specificity of EEGs is that there are, many children who may have abnormalities on their EEG, but may not have underlying epilepsy or even seizures, especially if they have conditions underlying ADHD or autism. And that affects some of the specificity numbers for the diagnosis of EEG. As we say here, here's a comparison compared to children versus adult from a recent publication in 2016. And as we all test, we need to understand how the test influences our decision making, which means that we need to have some degree of a pre-test probability going into the test and then understand how that test influences or helps us, either become more confident or in both ruling in or ruling out the diagnosis. And as you can see, some of these degree, the numbers, can increase and can make you more confident if you have a higher suspicion of an underlying epilepsy as well. But EEG, of course, beyond just confirming the diagnosis, can also tell us about the underlying epilepsy syndrome, the type of seizures that you might be dealing with, and other comorbidities or conditions that you might need to pay attention to. How can we improve upon that? So, if we just got us, as we discussed, just a routine EEG, just a routine awake EEG, the diagnostic yield may not appear that high. But if we get EEG relatively soon after, especially after a bigger event, we get sleep-deprived EEGs, and specifically if we get prolonged video EEGs, so overnight video EEGs, we can definitely improve upon the diagnostic yield of these tests. Which just means that if you have a high enough clinical suspicion, and if the EEG is normal, such as the event of stereotypes, the semiology is very convincing, repeating and making sure that you obtain sleep on the EEG or considering a prolonged video EEG should be the next step that you should be looking for and considering to be able to make the definitive diagnosis. And here is, again, here's a chart just showing the different epilepsies and how the transitions between sleep and wakefulness relates to epilepsy and a lot of the EEG findings. And that's why the importance of obtaining sleep and capturing the sleep-wake transitions on the EEG to understanding, diagnosing, and both epilepsies and the severity of epilepsies in this case. So it allows for better management and anticipation of any potential seizure, high risk of recurrence, and sometimes if they are, there are features such as what's called ESES or increased epileptic activity in sleep, whether they are affecting development or cognitive development overall. That helps us understand this relationship, help understand some of those conditions better. A lot of seizures can be very specific. Benign Rolandic epilepsy seizures classically happening within an hour of falling asleep during that early part of sleep-wake transition. Seizures in JME and some of the adults in onset generalized epilepsy syndromes may happen towards wakefulness, towards early morning seizures. Frontal lobe seizures happening more so in the middle of the night during the non-REM sleep and happening in clusters around then. So again, with some of these patterns and some of that, specific histories, understanding the relationship of events, understanding the EEG findings with respect to the sleep-wave transitions can go a long way in understanding the underlying epilepsies and understanding what treatments might work better for some of these patients. Some of the red flag situations that require urgent evaluations, of course, status epilepticus, seizures lasting more than 5 minutes, recurrent seizures without returning back to baseline, focal neurological deficits persisting after a seizure, a severe headache that persists after a seizure, especially associated with altered mental status, fever, again, altered mental status beyond the expected post-ictal period. These are things that should point towards more expanded evaluation than just kind of a routine initial evaluation with an EEG or from an epilepsy perspective, because these signs might frequently point towards an alternative etiology or alternative neurological condition, whether that be infection, stroke, injury, where seizure is the presenting sign of a more acute neurological condition. This presentation not focused a lot on treatment, but just briefly mentioning, of course, benzodiazepines are the first-line treatment for acute prolonged seizures, status epilepticus, used as rescue medications for out-of-hospital seizures. Common medications you will see being used in levetiracetam, lamotrigine, or oxcarbazepine. And for generalized epilepsy, using either valproate or, again, lamotrigine. Absence seizures specifically being treated with ethosuximide or valproate. Again, the goal initially, at least at the onset, is seizure freedom with minimal side effects, starting low, going slow, and titrating to effect, and emphasizing treatment adherence is very important in these patients populations. Thank you, everyone, for listening to this talk.
All right. Thank you, Dr. Jane. And thank you, everyone. We're out of time for today, but thank you, everyone, for joining us. And you will receive an email with a link for a CME evaluation and credit. And reminder, please join us next month, Wednesday, June 17th at noon for updates in pediatrics live stream. And the topic will be ADHD. All right. Thanks, everyone. Have a great week.